Okay, so tonight we're going to talk about Freudian theory. Um, Now, I know that most of you have had something on Freud. Uh, some undergrad programs focus a lot on Freud. I'm not sure why, maybe because it's like historical. Um, I do know that in Pittsburgh, there is a psychoanalytic institute, so it's still around. And I know people who are attending it, which is kind of interesting. Um, and but um, you know, hopefully, so I have to go over the basics just in case you haven't had Freud before. But hopefully, I'll add some stories and some info that'll make it a little more interesting for you if you've had Freud before. Um, so if you Uh, in the notes, I start off with a picture of a dog on a couch. The intrinsic problem with pet psychology, get off the couch. Yeah, I know. It's like a dad joke. Uh, so, um, you know, Freud's theory is called psychoanalytic theory, but he's also a developmental theorist, one of the first developmental theorists. And, his developmental theory is psychosexual stages of development. So you've got two different types of theories. They go together. One's developmental, and, the psychoanalytic one is more for therapy. Um, so the first thing I'd like to say about Freud is basically that, there's a lot of things wrong with Freud's theory. Everybody knows that. Uh, and, it has a lot of biases. It has, you know, um, a lot of things that really aren't conducive to, multiculturalism or, other things. So it's easy to criticize Freud's theory. But what I'd like to challenge you to do is to simply think about Freud in his own time period. And so, if you take him within his own context, you know, society, uh, there was not as much equality, there was not as much, feminism or multiculturalism, uh, a lot of issues at that time period. We're not perfect now. We have a long way to go now. But there's a big difference between now and when Freud was creating his theory. And the interesting thing about Freud's theory is that, you know, Freud wasn't the very first person to have a psychological theory, but he was one of the first, and he had one of the most expansive at that point. Um, so, you know, having original thoughts uh, in a previous time period was, at least he had some originality. He got the ball rolling, and we moved on from there. So I was surprised when I became a therapist uh, about a lot of things that uh, were unexpectedly true about his theory. And I'm going to tell you some stories about that. Um, but, just try to put them in context. And it's up to you what you take and use and what you just see as history. It's totally up to you. So, you have the freedom to choose what you want to use and, incorporate into your own therapeutic milieu. Okay. So, the first thing I do is kind of give you a little history on the person, kind of a synopsis of the person. And just so you can think a little bit about the character. And so, firstborn child in a family of three boys, five girls, born 1856. So that's the time context. In Moravia, now it's Czechoslovakia. Moved to Vienna early on when he was four. So 1860, he was in Vienna. So Vienna is one of the first schools of psychological thought. And another school that began very early was the Paris school, but Paris really looked more at diagnoses. And even today, they have some of the original books and a lot of the diagnoses that we still use today, like Tourette's syndrome, uh, were basically discovered or named, you know, in the Paris school. So that was also a very early school, but it wasn't so much practicing treatment and theory. It was more famous for kind of like, I would say the diagnostic process. Uh, so those are the two schools in Europe that are pretty famous. And then when we think about Freud's family, uh, they were Jewish and they really fostered um, learning, academics, intellectual issues. The father was very authoritarian. A lot of the opportunities for Jewish families at that point were limited. So a lot of them went into the medical field or law, because if you think about it, if you bought property, had a store, became successful as a merchant, and there was prejudice and whatever happened made that store close, everything was lost. But a physician or a lawyer could take those skills wherever they needed to go. So it was a portable skill. Um, and so, you know, he went to medical school, University of Vienna, lectured there 4 years later at the age of 26, which is fairly young, and devoted the rest of his life to developing his own theory. In his 40s, he started having a lot of psychosomatic symptoms. So if you think about the word soma, it means body, and psycho means mind. So psychosomatic means physical symptoms caused by the mind. And so he was experiencing all kinds of things. He was, having constant upset stomachs and couldn't sleep and had anxiety and, started having phobias about fear of his own death. So being a physician and developing his own theory of psychoanalysis, he started looking at himself. And one of the things he also noticed happening was he was having quite a few dreams at that time. Now, so he started analyzing his own dreams and looking at his early childhood. He realized he had a lot of hostility towards his dad because his dad was very authoritarian. The weird part is that he had some sexual feelings towards his mother, and Freud was more fixated on sexuality than a lot of other theorists. So that's kind of his personal issue, you know. So he was he was at the University of Vienna and working as a doctor in Vienna, the same time as a lot of other famous theorists. So, Erickson and Adler and Jung, a lot of these very early theorists worked with Freud at different times. So Adler really worked with him extensively. Jung was one of his best friends. And, you know, if he had opened himself up to suggestions from his peers, he would have a really comprehensive theory because they wanted to broaden his theory beyond just sexuality and early childhood experiences. So, unfortunately, it was his way or the highway. And so he even broke ties with people who wanted to add to or enhance his theory. And they eventually just came up with their own theories. So Adler has his own theory that we'll look at next week, and Jung has his own. And, you know, so I think his theory would have been a lot better had he just accepted input from other people and included their ideas. Um, so, you know, I think that one of the interesting stories that I read about was when he was when he was very young. Um, he had a nanny, and this nanny happened to be Catholic. And he spent most of his time with this caregiver. And she would, of course, take him everywhere she went, whether it was to church or, any other religious thing. And she was fired abruptly, unexpectedly by the father. We don't know exactly why. Some say, claim that she had stolen something, but there was probably a reason that the father saw religious conflict or something else. And so he lost this caregiver who he had formed a really close bond with at an early age. And eventually, because of that conflict, that religious conflict, and the loss of a person who was really close to him, unexpectedly, he eventually became an atheist and viewed religion as a neuroses that people use to help them deal with death, life, other things. He actually wrote a small book on that. And, so I think that a lot of things about his theory, we do have stories um, about Freud. One of the big questions I get from students is, was Freud a coke addict? So, you know, there's a lot of things about that time period. So, cocaine was a new drug. And remember, he was a physician, and they would use cocaine to treat everything. It made people feel better. And so that's why Coca-Cola has that name. So it used to have a pretty potent dose of cocaine in Coca-Cola. But being a medical doctor, Freud thought this was a wonder drug. Of course, he was having all these psychosomatic symptoms, and he was, sometimes experiencing phobias and everything else. And he could be positive. He could work long hours. He made him feel better. But one time, he no longer had any available, and he felt, the pains of addiction. And as soon as he felt that hint of addiction, he did not like that. And so he stopped using it. And so it wasn't like a lifelong addiction, you know, and it was kind of like a sign of the times. This was a new drug, and a lot of physicians prescribed it, and it's still used in the medical field today. Anybody know what for? eye surgery. So, yeah. So the other drug that he did not use is opium in the form of morphine. And a lot of times, if people were addicted to morphine, they would use cocaine as a treatment and vice versa. So, you're just kind of switching addictions. Um, so it's kind of an interesting thing. Um, so when we think about some of the contributions that he made, he was the first one to really think about an individual's personality. And you all kind of know id, ego, superego. So I'm not going to get into that a lot, but I used to use movie references all the time, and everybody had seen the movies. But now a lot of you probably haven't seen my movie references. But if you have seen Animal House, which I don't know, I think every college student should probably see, uh, you know, there's a scene where a young man wants to be liked and he becomes involved in a fraternity and invites a girl he met to a fraternity party. She drinks too much and he has a moral dilemma, you know, and he's wondering what he should do. Should he be a moral person, take her home to the parents? Should he take advantage of the situation and be immoral? And so when you think about id, ego, superego, ego is kind of his mind in the middle. And on one shoulder, a little devil popped up. And that's kind of the animalistic nature, the id. And, that's telling him to be immoral and take advantage of the situation. The superego popped up as a little angel and it's telling him, remember your conscience, be a good person, do the right thing. And fortunately, he did the right thing, took her home, and they ended up dating. So, but that's kind of like id, ego, superego. The ego is kind of the mediator, and id is more animalistic nature of humans, and superego is more like our conscience. The second contribution is defense mechanisms. And I see defense mechanisms being played out all the time. And a defense mechanism is not a good thing. It is not a coping mechanism. People get defense mechanisms confused with coping mechanisms. Coping mechanisms are okay. We learn coping mechanisms that help us through difficult times. But a defense mechanism is an unhealthy way to deal with a personal issue. So we're going to go over the defense mechanisms. And the last thing is his stage development theory, psychosexual stages of development. And one of the criticisms of psychosexual stages of development is, of course, too much focus on sexuality, even when it's not appropriate. Another criticism is that he only takes it up to puberty. He doesn't go throughout the whole lifespan. And so Erikson's stage theory is, if you put Freud's theory next to Erikson's theory, the time periods are very much the same in the stages of the development, but the stages are very different. And so I really like Erikson's theory. And Erikson's theory also spans the entire lifespan. So yeah. And Erikson knew Freud, and Freud could have enhanced his theory a little bit, but he chose not to. So Freud believed that a lot of individuals' issues took place in really early childhood, like before the age of 6. And so a lot of his theory focuses on the past. And, I think his theory has a lot of blaming going on. Not that it's not true. Yeah, nobody's parents are perfect. You know, parents are learning how to parent as a child is growing up. And I learned how much I didn't know when I had children of my own. And I used to teach the course lifespan development. And so, and I taught it at a time when I didn't have kids. So I started teaching it and theory, so lifespan and theories. I taught both those courses when I was just starting to teach. And I didn't have any kids, but I had three cats. So in order to give real life examples, I used my cats as examples. Now I can look at my kids and use them as examples. So I'll give you both. I'll throw out both examples if you're a cat person or a kid person, either one. So let's talk first about kind of the medical model. Of course, Freud used the medical model because he was a physician and it just made sense to him. Okay. So he followed the same steps to treat a person psychologically as he would treat a person physically. And so the first thing is diagnose the problem or issue. And I see this in the hospital setting today. When I'm working with psychiatrists, the first thing they want to do is discover a diagnosis. And, we use, DSM and um, try to figure out exactly what's going on with an individual. And that narrows down treatment possibilities. So, the next thing we do is decide how are we going to treat this individual? If they have this diagnosis, what's the best treatment to help them? And so, because it's a hospital setting where I work, and the so we're dealing with severe psychosis, and so sometimes the causality is you know something natural. It could be a parasite, it could be mad cow disease, which is not treatable. It could be all kinds of things going on with an individual physically, or it could be more psycho-emotional, could be a combination of the two. So really figuring out what's going on leads to an appropriate treatment. So the next thing, number two, is prescribe the treatment. Okay, this is our plan. This is our treatment plan. When you take the DSM class, you're going to look at all of the DSM diagnoses. And the first time you learn about a diagnosis, you're going to think, oh, I have this diagnosis. And then when you realize you don't have the diagnosis, you're going to realize, oh, somebody in my family has that diagnosis. And then you're going to put it more in perspective. And, and then you're going to come up with a treatment plan. And so prescribing a treatment. The third part is actually treating the patient. And the fourth is hopefully arrive at a cure. So that mirrors how a physician would treat somebody with a physical ailment. So it's interesting because I personally used to shy away from the medical model because I don't believe in labels. And I think sometimes if an individual is given a diagnosis because of all of the electronic records today, sometimes they carry that diagnosis with them for the rest of their life. And too many people have access to it now. And one of the other reasons why I shied away from it is because over the years, so many individuals that I treated were misdiagnosed. Yeah. Yeah. Right. So what you're saying, so for 90%, I agree because right now we don't have a cure for a chemical imbalance, something like that. We can treat it. And as long as they're taking medication, it can help considerably. Uh, However, um, I think that I have run into issues where we have found a cure because it was physically based. So individuals have had parasites and individuals have had the result of viruses. And uh, I think so. One of the stories is that an individual was bringing her child to see me, but I noticed that the mom was really depressed and down and lethargic and sad, tearful. And so, of course, I asked the mom, "What's going on?" And she said, "Well, I'm having liver problems, I'm having kidney problems, and the doctors don't know what's wrong with me. And I'm depressed and lethargic." And so she had gone through a loss, and she had complicated grieving. But in order to escape, so I asked her, I said, since the doctors couldn't figure out what was going on, I said, well, can you just, so this is what I do sometimes. I just say, walk me through a day from the time you wake up to the time you go to bed. And she says, well, I wake up, get my child ready for school, we eat breakfast, I send him to school, and she sleeps during the day. And I said, well, that's kind of an escape mechanism because you're depressed and grieving and you haven't seen anybody about those emotional issues. What do you do during the night since you sleep all day? And she said she sleeps all night too. And I said, well, how do you sleep all day and all night for weeks? And she says, oh, I just take Tylenol PM. And of course, it was the overdose of Tylenol in the acetaminophen in the Tylenol PM. People don't see that, you know, and of course, that was causing liver damage and kidney failure and everything else. Um, so, the other thing people don't understand is that when a doctor asks, what medications are you taking? They'll tell them all the prescriptions, but they won't tell them any of the over the counter medication. They won't tell them like supplements like vitamins or things like that. And often those are the issue. So, of all the legal drugs, um, Tylenol has a pretty high death rate. Um, and now they can treat Tylenol overdose pretty well, acetaminophen, but they'll usually use like NAC and do a kidney and liver cleanse and things like that. Um, but the number of overdoses are extremely high, even though the mortality rate has gone down. Um, so sometimes there is a cure, but you're right. 90% of the time, it's just ongoing treatment. But I really like it when there's a cure. It's like a mystery. Yeah. Yeah. A tumor. Yeah. 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 So I just think it's interesting, but you're right most of the time. Yeah. But that's kind of the mystery I like about like working with like really severe cases, figuring out what's going on. So, like I said, I used to shy away from the medical model. And if people just see me like in an outpatient setting, I still don't like the medical model. But in a severe setting, it's very useful. Yeah. I think the thing I don't like it about it the most is that I found so many cases that are misdiagnosed or overdiagnosed. And that's one of the problems with it. All right, any questions or comments about anything so far? All right. Um, so one of the things we should probably do is go over the psychosexual stages of development. Um, so a lot of the interesting things are that Freud took everything from a sexual perspective, and that was kind of his own issue. But I think he kind of misinterpreted a lot of things. I see some of these things in my own kids, but I don't see it in a sexual way. So some of these things definitely happen. I just don't think they're of a sexual nature. And we'll talk about that. So the first thing, the first stage, oral stage, birth to one. So he was really focused on the sucking impulse. And so it fulfills, it's instinctual. We're born with, and it helps us meet our hunger needs. And he sees it as meeting the pleasure need of a child. I think he sees the word pleasure differently than most people. By pleasure, I see it more as nurturing, comforting, loving, feeling safe. Like if you hold a child and give them a bottle, they feel secure and safe and loved. So they're getting that hunger need met, and they're also getting that loving, nurturing need met. And of course, they enjoy that. It's a nice combination where they feel safe and loved. Um, but he always sees it from kind of a human sexuality aspect. But I see a child, uh, feeling safe and loved and comforted, and of course they like that. So you know, I think that he's watching the same thing that I see, but he's seeing it from a little different perspective. Um, so um, you know, uh, I think that yeah, one of my friends has been bald most of his life, and just for fun, we would take all my kids and hold them up to his head, and it'd be like a suction cup, and we'd try to pull the kid off, but just to kind of demonstrate the natural instinctual sucking mechanism. Uh, so there are a couple things. So oral incorporative, um, he calls it the pleasurable stimulation of the mouth. If deprived of this, oral fixation might result later in life. He knew he had his own oral fixation. He smoked cigars and pipe. He eventually had jaw cancer and suffered quite a bit as a result of that cigars. Um, the uh, the interesting thing I saw. So when I was just starting out, had my master's degree, opened a private practice, um, and my practice was in with three other therapists, and they were all women. I was in a very small rural town, and I learned an awful lot from them. Um, and but because I was the only male therapist, I got a lot of kids who had experienced abuse issues. I got a lot of male children, and I don't really differentiate therapeutically between a male counselor or female counselor, male child, female child, whatever. Um, but parents or guardians often prefer a certain gender. So I ended up having a lot of male clients, children who had experienced some type of trauma. And so I did a combination of play therapy. I had a play therapy room, and then I had a talk therapy room with chairs and couch and everything like that. And so I would begin doing play therapy with kids. And after a while, if they had experienced some type of trauma or abuse, um, and I had all kinds of toys. I had babies and baby bottles and everything. I had sand tables and expressive arts supplies, all kinds of things. So they had a lot to choose from. But when we began to develop a trusting relationship, a therapeutic relationship, and they really felt safe, they began to play out uh, a different age. And it was usually a younger age, and it was the age in which they were abused first. So a lot of times they would regress and they would suck their thumb, or they would pretend to be younger than they were. And I was surprised by this because I really wasn't into, Freud's theory and kind of regressing to an earlier stage of development. But once they seemed to work through that stage, whatever it was, they kind of moved on to the next stage in their play. So I did find it fascinating. Um, the next term, oral aggressive. And this is when somebody is teething or biting, and says if deprived of this early in life, adults may use sarcasm or biting comments. So, of course, as soon as I learned this, I went to my mom and I said, "Did you deprive me of, teething, you know?" And when I was a child. And she's like, absolutely. She wasn't going to have her kid walking around town with a binky in their mouth. So I was deprived of that. And I use that as an excuse for my sarcasm still today. Um, so during this early period, and I would say even more so with Erikson's theory. We're not going to go over Erikson's theory because you're going to go over it in lifespan, human growth and development. But I like Erikson's theory that talks about trust versus mistrust during this early stage. And so it's not just about kind of the oral fixation, it's about that bond with a caregiver. And if they have a nurturing, loving bond, we could say, well, Bowlby talked about developing attachment bonds at this very early age. And Erikson talked about developing trust versus mistrust. And so when I was working with children and youth for some years, I noticed that if that very early bond wasn't present, so if you think about parent or guardian who had a severe addiction, their priority was the addiction. And oftentimes the children were neglected in some way. And that's how they ended up in foster care. And I got to see them when I was working for children and youth. But a lot of times, if this early bond during the first few years of life isn't developed, they don't develop trust and they don't develop attachment. And that could lead to reactive attachment disorder, RAD. And that could then lead to other issues as well, like some kind of conduct disorder or something like that. But this idea of trust, uh, you have to develop that early trusting bond, or it's very difficult to trust when you're older. And so, and it takes years to develop that trust if you don't get it at a very early age. So, all right. Anybody have any examples from the oral stage? Anybody want to share anything? Nothing? No good stories?
Can you hear me? Can you hear me?
Yeah, just a second. So, what are you saying? Oh, for anything in the oral stage. Yeah, I'm asking for like personal stories or examples. Yeah. Well, okay. So you have a similar experience to me. And who's going to talk on the on Zoom? Somebody asked if I could hear them.
Oh, that's me.
Go ahead.
Yeah, I was going to say something about the oral stage.
Go ahead.
Just for example, I don't know if this is correct or not, but when I was younger, I sucked my thumb. My mom was really, really cross about that. She didn't like it, and she put pepper on my thumb, just make me sniffing it. And for some reason, I've got this intense need to smoke. And it's just like the hand mouth movement.
Yeah.
It's just constant. And if it's not that, it's probably just having like a bottle of water or something, always just having something, hand to mouth. So I'm not sure if that's, a deprivation thing or how it relates to this theory, but just that when you're speaking about it, it just kind of, a light bulb went.
Yeah. So I don't know if it's true or not, but Freud would say, yeah, that's it. Yeah. All right. Well, let's go.
Dr. Grafton, can I just say something real quick?
Sure, go ahead.
We, for some reason, when you're listening to the people in the classroom, it like literally sounds like no noise is happening at all on our end. So
Uh, yeah, so
I
I'll repeat what they say.
okay, gotcha. I just like it just looks like you like kind of freeze out sometimes. I'm like, wait, what's happening? And I
Yeah,
see
it's
you're
me
like,
listening to the
yeah.
Okay, yeah, I'll definitely repeat what they have to say for you. Thanks.
I was gonna say, I wonder if that's connected to like nail biting because I bite my fingernails all the time and I cannot get myself to stop.
A nail biting? Yeah, that's a good example too. What was your question? I don't know. Can we use it on animals? That's a good question. Hmm. Yeah, so food aggression, like whether you have a an animal that's been loved from birth or whether they were a stray, they have very different personalities. Yeah. Yeah, definitely, definitely. So yeah, I guess a lot of it might have to do with animals as well. Yeah. I mean, I have a cat that's a little more feral than my other cats that we got from birth, and yeah, he's a little crazy. So, all right, well, let's talk about the anal stage. This is a time of like toilet training, potty training, leading to anal retentive habits. Uh, so, children, any child, becomes interested in feces and going to the bathroom because we focus on it. We want them to use the bathroom, and because it comes from them, they create it, you know? And they never really thought about it before because they were wearing diapers. And so I had one client who was abused at a younger age and had a wonderful foster family, and they were going to adopt them. And um, they worked with me all the time. They would come into the sessions with me. And I got a call one time, and they're like, Grafton, we just thought we'd call you because this child was painting the bathroom with their feces, and they just thought this was bizarre. And I know that a lot of children in this age range want to play with their feces. And, so if you think about some child who's only 1 to 3 years old, they might do that just out of personal exploration. And yeah, it's disgusting. It's a mess. But my response, because this child was 10, um, was that, wow, I'm thinking, wow, he's regressed back to that early stage and he had been abused when he was 3. And so here I saw this example again. And I said, wow, this is fantastic. And they're like, well, I don't know how fantastic this really is. And but fortunately, they didn't get angry. They didn't like punish the child. They just gave me a call. And I said, well, so I explained the whole thing and the theory and that, he was working through the stage where he had been abused. And, but it would be best if it's a positive experience. So, we just came up with an appropriate consequence which was since he was 10, he just had to clean it up. He made the mess, he had to clean it up. And it only happened one other time and then he moved on. Um, but it was kind of a neat example. And so lots of times children urinate if they're not getting enough attention, like if parents or guardians have friends over and the child feels a little ignored. One of my friend's kids just walked in the middle of the living room and peed in front of everybody, and that got him the attention he wanted to get. Um, and so, when I was in my master's degree, we were all living in apartments and uh, we really had a nice community, me and the other students. And some of the students were married and just having kids, and others were single or dating like me, but we would all babysit for everybody. It was like a real nice community. And so I really spent a lot of time with my friend's daughter and babysat a lot. And so he was a little anal retentive himself. And um, he did not want his child to be like him. So he was like a self-help guru. He would read every self-help book on the market and he would buy them for the kids. And so I got a call. He's like, Grafton, come over. I want you to see this. So I rush over and he knocks on the bathroom door and he's like, Catherine, are you decent? She's like, yep. And we went in. He's like, show Grafton. And she like looks at the toilet and flushes it and waves, bye bye, poopy. And he was so excited because, I guess potty training had been a little stressful for him. And he thought that was the root of a lot of his own issues. And, but he had bought a children's book, and every night they were reading about how to use the potty. And whenever she was ready, she could try potty training. So no stress at all. And, you know, um, so even, uh, even if, um, potty training goes well. I think there's a lot more to this than just potty training. It could be the parent's whole personality. So, because Catherine's still a little anal retentive to this day. But yeah. So, I think he talks about being anal aggressive and if harsh methods are used to toilet train a child, and they may later display anger, aggression, or anal retentiveness. One of the problems is I don't like it when people say, oh, I'm OCD, because, you know, anal retentiveness is really very different than obsessive compulsive disorder. Um, One is OCD is much more extreme with obsessive thoughts and compulsive actions, and it has a lot more to do with a chemical imbalance. Uh, but anal retentiveness is about control. So everybody sees it about having to have a desk in a certain order or something like that, having all the shoes lined up just perfectly, or whatever it is. It's kind of like perfectionism. But um, anal retentiveness is about being forced to have control as a young child when maybe they weren't ready, or maybe too much emphasis was placed on being in control. And then they feel as an adult, if they're not in control, they don't know what's going to happen. So it creates anxiety if they're losing control or feel out of control. So the unknown scares them. Not being in control scares them. And so, anal retentiveness is really about having control and the fear of not having control. So when we talk about the phallic stage, period of walking and talking, and um, you know, uh, Freud focused on a new attention to the genitals. But think about it this way. So if a child is wearing diapers up until this point, and they just learn potty training, they've really not experienced that part of their body much. It was always covered. They got changed, got a new diaper on. And so at this age, I see it more as like curiosity, personal exploration. I don't see it in a sexual way. Um, and he talks about the Oedipal and Electra complex, and, you know, um, so, finding a father or mother uh, sexually attractive. Um, I don't really see it in that way. Freud might have had that in his own life. What I normally see is that one parent becomes a dominant caregiver in a child's life for whatever reason, maybe different working hours, whatever it might be. Um, and the child uh, forms that bond with them. And at this age, the child is like, hey, what's going on with this other caregiver? When I'm with them, they give me a lot of attention. Might not be the same, but it's fun. So I want to get to know them now. So first they develop this really close bond with a primary caregiver. And then at this age, they want to get to know the other people in their lives as well. So I see it more as that than anything sexual. Now, I did have one experience with a child at this age um, that Freud would definitely say was sexual. I I still don't see it as that sexual, but so when I was a school counselor in an elementary school, I had, and this happens all the time. This is not rare, uh, but it was new to me at the time. And I had a third grade teacher run down to my office and tell very upset that a little girl had a third grader was masturbating in the classroom. And so, I said, well, let's not call attention to this. Nobody had noticed. And so I just observed the classroom. I said I was observing the teacher. And and what I noticed was every time this child became stressed, like if they didn't have their homework done, or if they were having a quiz or a test or something like that, this is a way they just happen to find relief for their anxiety. And so I decided I didn't want to focus on this. We did talk to the parents. They took her to the doctor. There weren't any physical problems, no abuse issues, nothing like that. She had just discovered this way to relieve anxiety. And so I went to the class and I gave lessons on um, how to relieve anxiety if you're taking a test or stressed out about things in your life. And we went through like all types of stress inoculation and relaxation exercises. And we also talked about study skills and how to prepare. And I said, if they wanted to, they could bring in their favorite stuffed animal. And if they're feeling anxious, they could hold the stuffed animal in their lap and pet the stuffed animal until they felt more relaxed. And um, and so a lot of them did that. And the teacher always knew who wasn't prepared for the homework or the exam. But with that substitution of a stuffed animal and teaching them about relaxation and how to de-stress and how to prepare, it just extinguished itself. And so that's what I wanted to happen. I just kind of wanted the issue to go away because if we had made a bigger issue out of it, it may have affected her later in puberty, and I just wanted it to extinguish itself naturally through substitution. So, and this is fairly common at that age. Um, the Just to share my cat story, um, the I had, if you work in an elementary school, you end up with a lot of cats, especially if you're in like a rural area. You just hear meowing from kids' lockers. And of course, the janitor has to come and open up the locker and they find a bucket of kittens. My daddy's going to drown the kittens if I don't find a home for them, and all the teachers take a kitten. And so I ended up with like three cats. And one of them, uh, his name was Cosmo. He was born under Halley's Comet. And so he was a little more dominant than the other two cats. The other two cats were older, and he would be sexually aggressive with them. And I said, well, Cosmo, I'm sorry, buddy. It's time to go to the vets and you know, and get neutered. And he came back and healed, and he was still sexually aggressive. And I and the other cats didn't want anything to do with him. And so I called the vet. I'm like, hey, did you miss something? He's like, no, that was, that's the way the cat's brain is working because he wants to be the dominant cat in the pride, and you've got three cats. And I said, well, what should I do about it? And he's like, well, we have Kitty Prozac. And I'm like, I am not giving Cosmo Prozac. And so I thought about it and I said, well, if it worked with the third grader, it'll work with Cosmo. So I went to the toy store and I was going to buy a stuffed animal to substitute for the other cats. And the movie 101 Dalmatians had just come out. So the only stuffed animal they had was Dalmatian dogs. And I said, is that going to mess Cosmo up if I got him a dog? And I decided to get him as his own Dalmatian. And every time he was aggressive with the other cats, I would remove him and give him his Dalmatian. And they bonded and they were best friends the rest of their lives. So it worked for Cosmo too. But all right. So we're nearing the end of our uh, developmental theory here. We have latency. It's kind of like he called it a more narcissistic orientation, lowered sexual attention. Children develop same gender bonds. If you think about it, this is when they go to elementary school. And when I was younger, um, a lot of times the boys would play together and the girls would play together, and didn't have to be that way. But I think there's a lot more mixing today. Um, but, you know, uh, that's kind of what he was seeing. And he called that latency. But then in puberty, the last stage was the genital stage. Of course, we know with puberty, Erickson would call it personal identity versus role confusion. But this is when we start, dating and thinking about work, and, you know, phallic themes are revived with the onset of puberty. So this is probably on target with him, but that's appropriately on target. Um, and yeah. So any other comments, questions, or examples from any of these other stages? Crickets. All right. Well, that's okay. Um, so he believed that anxiety um, was kind of a conflict between the id and the superego, and the ego felt conflicted. Um, he thought that neuroses could be the result of this. So I just want to run through the defense mechanisms briefly with you. You should know the defense mechanisms. They do happen all the time in clients. And so if somebody displays a defense mechanism, I usually talk about it and try to come up with a more positive coping mechanism, or figure out at least the cause of the defense mechanism. So talking about it usually extinguishes it, as long as they're thinking about it. So repression, anxiety producing thoughts are excluded from consciousness. And the next one is denial, paddling up a river called denial. Um, so distortion of reality, thoughts, feelings, or perceptions that can produce anxiety. So the difference between repression and denial. Repression is that anxiety producing thoughts are excluded from consciousness, whereas denial is distortion, not exclusion. So they're the same, only that's the difference between the two. Distortion versus exclusion. Reaction formation, to actively form and express actions opposite to the impulses one actually experiences. Being kind when you're actually angry. Um, so like I always knew whether my mom liked the person I was dating or not. Um, so uh, you know, the she would have kind of an opposite um reaction. So if I brought my date home for dinner, um, if my mom just treated them, normally, she liked them. If my mom was like super nice to them, she couldn't stand them. So it's kind of the opposite reaction to how you actually feel. Um, Projection. The thing with projection is if you ever define projection, don't define a word by itself. So you can't say projection is when people project. So you have to come up with another word to define it, attributing aspects of one's own personality to others. Um, Displacement, this I see an awful lot, redirecting impulses from an unsafe target onto a safe but inappropriate target. Person gets angry at their boss at work, comes home, is mean to the dog or a spouse, uh, who is more safe than a boss. That's why they say you always hurt the ones you love. It's displacement. Um, Sublimation, diverting unacceptable impulses, sexual or aggressive, into more acceptable. Like, if you were aggressive, you might join a football team or a rugby team or something like that. Regression, we talked about regression in my examples from play therapy. So that's reverting back to a previous stage of development. Introjection, conforming to the standards or values of others, taking on attributes of maybe a strong person who's able to better cope with a situation. So maybe imagining yourself as, you know, a good public speaker if you're afraid to speak in public. Identification is aligning with others or organizations to protect one's self-worth or perceptions. It's like joining a fraternity or sorority or gang. Same thing. Let's see. Compensation, concentrating on some positive trait to mask perceived weakness, or overcompensation would be uh, emphasizing a positive trait, going overboard on a positive trait. Like if a person is small and was picked on, they might start weightlifting and do it excessively to overcompensate, or they might buy a Porsche. Um, Okay, so transference and countertransference. Transference, the client's unconscious shift. So we're done with the defense mechanisms. Transference is the client's unconscious shifting to the uh, therapist or the analyst of feelings and fantasies that are reactions to significant others in the client's past. That's a little complicated, but so I've had clients where I reminded them of their father and they might not have liked their father. Their father might have been an alcoholic or something like that. And so I realized that maybe a client was angry with me, but so the first thing I do is check in with myself. Did I do something that might cause this emotional reaction in my client? If the answer is no, it's probably transference. And so we have to kind of call attention to it and unpack the transference. And as long as the therapist is aware of the transference and makes the client aware of the transference, and they're able to figure out what's going on, it can become therapeutic. But if the therapist is not aware of the transference and they become defensive, it usually alienates the client. So you kind of have to be aware of it happening. Countertransference is the opposite. When a therapist feels some way about a client that isn't on target. And countertransference occurs if a therapist has not dealt with their issues. Then they play out in therapy, even if they're the therapist. So countertransference is not appropriate. All right. Just real briefly, some therapeutic interventions. Maintaining an analytical framework means that you meet the same place, the same time, go through the same kind of steps in therapy. so that it becomes a routine. Uh, so it doesn't take up space in the client's mind. Free association, what's the first thing that comes to your mind? Word association, you have a list of words, you read it to the client. Mother, the client gives a reaction. You read the next word. Father, client gives a reaction. So it's kind of a more formal word association than free association. What I like to do, I like doing free association. So if I say mother and the client says father, then I reflect what the client says. Then I say father and I see what the client says. So it plays back and forth. So it's a way of helping the client follow a certain track of thought. Discovering early recollections. He really focused on early recollections. Dream analysis. So let's talk briefly about dream analysis because that's what your discussion board's going to be about. So Freud and Jung believed that they could interpret somebody's dreams, and that everything in the dream was symbolic. The problem with that is that they believed that a symbol was the same meaning for everybody. So a snake had the same symbolism for everybody who dreamt about a snake. Um, a monster chasing somebody meant the same thing for everybody who dreamed about a monster chasing them. So that's incorrect. So, um, so I use my own. So dreams come up in therapy all the time. And the most important dreams are dreams that repeat themselves all the time, um, or a vivid dream where you think it's actually happened and you wake up and it's like, wow, what just happened? And then you realize it was a dream. Um, so either a vivid dream, or they call it a lucid dream, or a repetitive dream that happens over and over again. So, what I do, if a client brings up that they had a dream like that, repetitive or very vivid, I ask, um, well, tell me about the dream. And they tell me about the dream. And then I say, so I don't interpret the dream for them. And then I ask them, as you were telling me about that dream or when you were in the dream, what's the feeling that you were experiencing? So if they were being chased by a monster, they might have felt out of control or frightened or threatened in some way. And then, and it doesn't matter what the feeling is, and then I take the feeling that they gave me, I reflect it, I say, so you felt threatened or afraid or out of control. And do you have those feelings in any part of your waking real life? And then they think about it and they say, yeah, I really do feel fearful of my new boss in this new job. And that's how I know what to focus on in the therapy session. So, not so much the symbolism of the dream, but the feelings that they had in the dream are representative of something happening in their real life. And then once they match the feeling up with something in their real life, then we can talk about what's happening in their real life. And that becomes the therapeutic focus of the session. So when you look at the discussion board and you share a dream, uh, think about the feeling in the dream and see if when you had that dream, if you had a similar feeling in your real life or not. And it might work, it might not. Sometimes dreams are just dreams, but oftentimes they're a reaction to something that's happening in our real lives. The last thing is basically criticisms of Freud. Um, it was the first comprehensive theory, which is a positive thing, but it focused too much on human sexuality rather than other aspects of the human condition. Um, the Some things are still useful today, like defense mechanisms. Um, it didn't take into consideration multiculturalism or feminist issues, equality. It had biases, used only the medical model. Um, the developmental aspect didn't include the entire lifespan. Um, his therapy takes a long time, years, years. Um, yeah, I think that's about it. All right, questions or comments about Freud? Anything want to add anything I didn't talk about? Maybe you've had Freud before and found something interesting that I didn't talk about. All right. Oh, Jessica, yes. You're muted, I think, or I can't hear your mic. Nope, no good. You can type it if you want.
I have a question, Grafton. What do you
Go
think
ahead.
about people who can never remember their dreams? Like, what does that mean?
So we have to train ourselves to remember our dreams. So the if we have an alarm clock and we wake up with a start, it's difficult to remember a dream. And if we move into a morning routine, that becomes our focus. But if you wake up gradually and you keep a journal by your bed on the nightstand and you continue to lay down and don't move into something that's different from resting in bed, and think to yourself, my next step in my morning routine is writing down my dream. It'll take a couple weeks to start remembering them, but you can train yourself to remember them. Jessica, what you're writing's incredible. That was it? Okay. Shama, what are you thinking?
Can you speak a little bit about the unconscious mind, conscious mind, subconscious, um, in relation to Freud?
Well, I believe that Freud thought that the unconscious was tied to our early childhood events and human sexuality. And so, you know, a lot was going on that we were not aware of. And the purpose of psychoanalysis was to make us more aware of what was buried in our unconscious minds. That's my interpretation of it. Jung was a little different. He believed in the collective unconscious, which is a little different. But that's just my take on it.
Thank
Who
you.
else?
High school in AP Psych, we had to leave a journal next to our bed, and as soon as we woke up, write down what we dreamed about.
So, yeah. Did it work for you? Leave the journal by the bed?
It's surprising because
Yeah.
my mother just reviewed this now. It made me realize that, like, wow, it really does work.
So good, it worked for you.
How well it described how I was feeling.
Nice. Did you do the feeling thing with the dream? Because most people don't.
We didn't go into like lots of detail with
Yeah. It was just remembering the dream. Yeah. Yeah.
But like,
So-
we talked
Yeah.
Like, how were you feeling when you dreamt that? But like, you didn't really make the connection.
Yeah. And so the next step would be if you have a vivid dream, to realize you have a vivid dream in the dream. That's kind of the next step. Vivid dreams are rare, though. Some people have more than others. But all right. Irene, did you have your hand up?
Yeah, so I was gonna ask, yeah, unconscious, subconscious, conscious, in connection with id, ego, superego, how
Yeah,
translation.
so I think Freud would say that most of our unconscious is more id related, because we have more instinctual animalistic tendencies. Um, and, kind of a higher thought process would be our super ego. And that's why we find ourselves in conflict that creates anxiety. Um, so I think he'd say that it was a combination of kind of more primitive instinctual things like the id, but in combined with some of our early childhood experiences that creates that.
So kind of the baseline is being a subconscious level, like the ego would be the subconscious in this comparison.
So I always thought the ego was the mediator
Mm-hmm.
between the id and the super ego.
Mm-hmm.
So it was kind of like the logical part, to find balance between the id and the super ego. Yeah. But it's interesting. I'm not a Freudian expert, I'll tell you that, but hey, we do have a psychoanalytic institute in Pittsburgh, if anybody's really into it. There are a lot of, so Princeton University has a whole collection of Freudian monographs of everything he ever wrote. And so I have a little collection of them. I've only made it through three or four of them. There's over a dozen, but some of them are pretty interesting. I'm more into Jung.
Oh, same here. I was gonna say, the case of Anna O. I remember studying. That's a popular one. And how often the dreams, going back to the dreams, um, our conscious might be, might think we're past it or healed or we're good with it, but the repetitive dreams of the unconscious popping back up, and um, I've heard people say that, and I've experienced it myself. Of
Yeah, so Jung would say that dreams are a window into the unconscious.
mhm.
Yeah. So we're not going to cover Jung, but Jung, they just published, well, I would say 20 years ago, they published Jung. It's called the Red Book, and it's kind of his diaries. And then they just came out with the Black Notebooks 2, 3 years ago. And they're actually published in his own handwriting and all of his journals that weren't included in the Red Book. Jessica.
Can you hear me now?
Uh,
Good. So I find dreaming very interesting, or just sleep in general. Um, so I led some groups on sleep as part of wellness, and we review that there is no known reason as to why we sleep, let alone as to a conclusive theory or understanding of why we dream. And so I feel that it's interesting how the continuation of trying to interpretate why, like what our dreams mean, let alone interpret why we dream in the first place. And there are several theories that kind of either for like repetitive dreams, maybe that are in the past, maybe we're fixating on going back and trying to change something in the past. Or avoid something, but we can't because we haven't faced it, or survival, just basic learning how to evolve as a species, and dreaming to kind of prepare ourselves for future threats and things like that. So I just wanted to share that because that's all very interesting to me.
Yeah, the science has discovered a lot of new things, like as we dream, spinal cerebral fluid moves up and washes our brains during REM cycle. And so there's a lot of studies on trauma. So if you think about somebody who experiences trauma, a lot of times if you experience trauma, you don't sleep that night. And so you don't get into REM cycle, and that cerebral fluid doesn't wash your brain. And so my own theory is that you know, using EMDR mimics the REM cycle. Yeah.
Yeah, and also like during REM cycle, our brain is half conscious in the half wake state. So maybe our brain is not able to actively suppress or repress elements of our memories, and they kind of are able to resurface during that dream state, and they kind of manifest that way. They have that some temporary kind of like relief, that gasp of air to come up to resurface to be processed at some point.
It could be. Yeah. And or maybe it's processing it while we're asleep. Like a lot of times if I can't figure something out, if I just let it go and go to sleep, I might wake up with the answer.
Yeah, that's true too. That's very, yeah, absolutely.
The brain waves also shift from, you know, one to probably delta and some other things. All right, good stuff. Yeah.
Sleep paralysis.
So sleep paralysis is really interesting, and it happened to me once. And so at at first I didn't know what sleep paralysis was, but it's when your brain wakes before your physical body connects to the brain. And so I almost felt like paralyzed. And like, what happened? Here I am awake, and I panicked, but I couldn't even scream or move. But it was only a few seconds, but it seemed like forever. And then, of course, I did a little research and figured out that's what it was. And I think like I was running and I injured a knee or something or a calf, and they gave me like muscle relaxants, and that's what caused it in me. So I had like a reason for it. But so I stopped taking taking them. But yeah, I think it happens naturally too, and it's a scary thing if you don't know what it is. Yeah. Yeah, interesting.